This week on the BackTable podcast.
I think that's just where the kind of the art of this comes into play. It's your eye for aesthetics. And so, does it look good to you? I mean, that's where, I don't really foresee myself ever doing any measurements in this area. It's really mostly like, okay, if this was your mom or your sister or your aunt, like, would you be okay with this, how she looks? So that's just like caring and honestly having a little bit of a creative mind and making sure it looks good.
Hello, everyone, and welcome to the BackTable ENT podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice. My name is Gopi Shah, and I have a really awesome guest today. I have Dr. Demetri Arnaoutakis. He's an otolaryngologist and facial plastic surgeon practicing in Tampa, Florida, and Beverly Hills, California. He specializes in facial plastic surgery, hair restoration, and injectables. And Demetri is here to talk to us about in-office facelifts. Welcome to the show, Demetri. How are you?
I'm great. Thanks so much for having me, Gopi. I'm really excited to be here.
For our audience, just to give some context, so Demetri was one of my residents for all years of your training.
I think, yeah.
Yeah, and it was wonderful. You were one of the hardest working people. I don't think I ever told you that, and now we've made this public. So Demetri was one of my favorite residents. He was so hardworking. It was such a pleasure to work with.
Thank you.
So before we kind of get into in-office facelifts, I want you to tell us a little bit about yourself and your practice.
Yeah, so I'm originally from Tampa, Florida. I was recruited to Columbia University for soccer. So I played Division I soccer for 4 years and really loved my time up north in the city. It was definitely a unique college experience. And then I returned back to Florida for medical school. I went to the University of Florida College of Medicine. And that's where kind of my first mentor in my training I met was Dr. Bill Collins.
Shout out.
Yeah, who was on the show not too long ago. And how I kind of heard about this. And he's awesome. He's the man. I mean, he was just such a great teacher. He let me get involved from, as a medical student, helping with, I think I even did, my first tonsillectomy under Dr. Collins. And I think I may have disappointed him a little bit when I didn't choose pediatric otolaryngology for my career, but...
You disappointed many of us when you did not choose pediatric otolaryngology.
Anyway, so then after medical school, I also actually, between my third and my fourth year, I applied and was selected for a Doris Duke research fellowship at Johns Hopkins. So I spent a year in their otolaryngology department, specifically their kind of head and neck cancer division. And that's where my second mentor came into my life, Dr. Joseph Califano, who's now out in California. And he was an excellent clinician and surgeon and researcher all together. And I got embedded in their otolaryngology department. I attended all their lectures. And that's really when I sort of started to take a liking towards facial reconstructive and aesthetic surgery. Dr. Patrick Byrne, who's a really well-known facial plastic surgeon, was really generous to me, and I got to watch and see a lot then as well. So by the time I got to Dallas for my training with you guys at UT Southwestern, I already knew the path I wanted to take in facial plastic surgery. And honestly, from day one, I was sticking to Dr. Leach and Dr. Gilmore and Jordan Rahani and the whole crew. And then after that, I was chosen for fellowship out in Beverly Hills with Dr. Andrew Frankel, who's a world-renowned rhinoplasty, revision rhinoplasty, and facelift surgeon. And then I came back to Tampa, and the rest is history.
Wow. So in your fellowship, then, is that where you got the bulk of your cosmetic experience as well as your in-office procedures?
Yes, it was definitely during fellowship, but also in my free time in Dallas. I mean, I think the smartest thing I ever did was I kind of reached out to all the private practice plastic surgeons around Dallas. And, so many of them are really involved in the AAFPRS, which is the American Academy of Facial Plastic Reconstructive Surgery. Sam Lamb, who's out in Plano, is a world-renowned hair restoration surgeon. And there's just so many, Rod Warwick, who was with the UT Southwestern department, and then also Sam Hamra, whose name may not ring a bell to a lot of people, but he was the first person to describe the deep plane facelift. And he was right there in Dallas, Texas. And he was towards the end of his career, and I would go visit him and watch him do deep plane facelifts in my free time. And he was awesome. Yeah.
So for our trainees who might be listening, how do you find time? At what points in your residency training were you able to go and shadow, watch, observe, work with some of the physicians that are outside of your residency training? How did you do that?
So it was really, I took advantage of our fourth year block of our research block. So I would, in fact, I did some research articles with a lot of these surgeons. Jim Thornton, who's a Mohs reconstructive surgeon within the plastic surgery department at UT Southwestern. He was so welcoming to me and just a really nice guy. And in fact, we had a referral of a collaborative patient recently. So I took advantage of that. I was still, I didn't, not do any research. I actually got a couple articles published, but I used all that free time, instead of sleeping in until 10 a.m. and taking advantage of the free time from your usual clinical responsibilities as a resident. I was still up at the same time, going around town, watching these guys in the community who have excellent reputations. And truthfully, there's a difference between what kind of goes on in the hospital and then in a boutique, 5-star plastic surgery practice. It definitely has a different aesthetic to it. So I really enjoyed that. And I learned so much from all those guys.
So, now for like the program side, because you're right, training programs are all a little bit different. But, you might be somewhere, well, maybe they don't have as much trauma, but you're interested in doing more trauma. Or maybe you want to focus on gender affirming voice care, but maybe they don't have a program for that. Or in your case, a real high-end cosmetics practice. Are there any advice or pearls or tips that you would offer to the training programs? Like what can training programs do to help bridge some of those gaps or help you utilize the other resources around you in your community?
Yeah, I think it's really helpful for the residency programs to be welcoming to the community doctors, especially a lot of our, alumni. I know a lot of the UT Southwestern alum are, within the Dallas-Fort Worth area, and they've obviously, had very good training. And I think, inviting them back to, not only attend the grand rounds, but to be guest lecturers. I think Jordan Rahani, who's an excellent facial plastic surgeon and a UT Southwestern alum, and he's still in the area, and I know he's involved. In fact, we did some injection workshops with him. So I would apply for a grant from Allergan or Galderma, the main, Botox, Dysport filler companies, and they would send us products, and then we would recruit some of our nursing friends, and we, do free Botox and filler on them under the guidance of, Dr. Rahani and Dr. Gilmore and so forth. And I think, little workshops like that are extremely helpful. And it was really a lot of fun too.
I think that's great. All right. So let's get into our clinical topic today. We're talking about in-office facelifts. I wanted to start with the basics. How do these patients present to you? Do they all know that they want a facelift, or do they even realize that that's what they need? How does that sort of initial visit go?
Yeah. So in my consultations, honestly, the patients come in. Obviously, we have our intake form, and they kind of write at the top, what's the reason for the visit? Sometimes they'll just write deep plane facelift. Sometimes they'll write my jowls are bothering me, or my eyelids, or my neck. And so as we get to know each other, what I usually do is just hand them a mirror. And I also have a stool and a mirror in my office where we sometimes we'll just sit in front of it. And the patients will point to things that, that they're self-conscious about. And then once they've kind of made everything clear, then I'll, do my assessment and sort of talk with them what I think is best. And a facelift isn't for everyone, right? There's downtime, there's cost, there's, the stigma perhaps of the scars around your ears and whatnot. And so some people are like, look, doc, there's no chance I'm ever doing that. What other options do you have? Obviously, I do some minimally invasive type facial rejuvenation procedures as well. And so I have to basically, give them all their options, and then they decide what's best for them. And they break it down, whether it's their financial reasons or scarring or downtime. And then we just decide, what's best for that patient. So then, after that point, if I can get a feel for what they're leaning towards, and then I'll probably give them a more thorough explanation of that route and give them, a day 1, a day 2 after a facelift. If truthfully they're interested in a facelift, then we just walk them down basically every day of their recovery from day 1 to, day 10 or 14 or so. And I think that gives them a more realistic idea of what to expect.
Are there certain questions that are always part of your history?
Yes. In this day and age, there's so many different types of injections and non-surgical treatments. And so, for example, there's something called PDO threads, and they're, sold as kind of a quick facelift, if you will. They don't last very long. There are these barbed wires basically that go underneath the skin into the dermis and SMAS, and then try to kind of lift up your jowls and nasolabial folds. And anyway, if someone's done that 6 months ago and you're going into surgery, you would like to know that you're going to run into that barbed wire when you're elevating the deep plane lift. So yes, there are certain things I'd like to know about, what they've done to their face and neck in the past.
And so you'll kind of go through prior procedures, filler or other sort of non-surgical or injectable or another.
Yeah, injectables, and it kind of falls into one big category there. And then, of course, their medical history as well. So, any cardiac issues, we definitely want to have them have medical clearance if there's anything concerning in their medical history. So we'll have them get EKGs, chest x-rays, blood work, and a clearance letter from their primary or their cardiologist or whatever it may be.
If the patient's a smoker, for example, how do you counsel them with like a history of smoking? Do you try to have them stop, perioperative? Is that even reasonable? Or is it just setting the expectations with that risk?
Yeah. So I think in the past, that would have been like a hard no for a lot of surgeons to just not operate on them. I think now, I think there's certainly been a trend towards, okay, they can safely undergo a facelift procedure, especially deep plane facelift. There's better vascular supply to the skin dermis area. So I would encourage, and I think a lot of plastic surgeons do this as well, is to have them undergo hyperbaric oxygen. Certainly, several sessions after the procedure. That just obviously increases oxygen delivery to the tissues. So I baseline have all my facelift patients at least do one session postoperatively. And for smokers, we would have them do at least, probably 5 or 6 just to, be safe.
And then how does age play a role in your decision making? And my other question it's leading into is when I think of medical management or less invasive surgical management, like how do you know when you're going to try fillers first or non-surgical versus going straight to a surgical? And does age play a role? And, what do you think about when you're teasing some of that out?
Yeah. Age does play a role to a degree. I mean, I've done a facelift on an extremely healthy 82-year-old before. I mean, it's really just a matter of how, the patient feels. I mean, that person felt like they were going to live another 15, 20 years. So in that case, why would I deny them just because of their age? They had no medical issues. They were extremely healthy. They exercised every day. They ate well. And so I thought the person was a great candidate. They did excellent. They were extremely happy. Usually in the 30-year-old, 40-year-old crowd, that's, obviously they don't have as much skin laxity. And so usually those patients are presenting for more minimally invasive or non-surgical options. I have done neck lifts though on patients younger in their 30s and 40s who just hereditary, we kind of call it now like deep neck fat. So when you do liposuction, you're targeting the subcutaneous fat, which, underneath the epidermis, dermis, but on top of, in the neck, on top of the platysma muscle. Now, deep to the platysma muscle in the neck and in between the submandibular glands, there's kind of this hereditary deep fat. And so now there's a procedure that I do a lot of, platysmoplasty or deep neck lift. And so you make an incision just underneath the chin and the submental crease there. And the platysma, as we know, is usually dehiscent in the midline. So we basically undermine the platysma bilaterally. And I usually do it for at least 4 to 5 centimeters. And you're in that submental triangle there, and I'll directly excise that deep fat. That's significantly different. It will provide a significant impact compared to just liposuction. Because after you kind of carve out that deep fat, then you take the platysma edges and you do a platysmoplasty. So you're suturing that up to like the hyoid fascia. So in females, you really want to have that strong sort of 90-degree cervicomental angle. And really the best way to recreate that in a natural appearing way and a long lasting appearing way is to do this sort of deep neck lift or a platysmoplasty as it's traditionally called.
And then just kind of going back to some of the initial review of history, are there any other medicines on their medication list that you have them stop or that are red flags for you?
I mean, certainly, anticoagulant medications, so Coumadin, even aspirin. I mean, trying to do facelift surgery or, any surgery for that matter, when they're on a medication like that, it's exhausting and frustrating. I mean, everything, you're bipolaring like every other tiny blood vessel. So I would not operate on a patient who's taking one of those medications. It's just not worth it. I mean, this is elective surgery, right? this isn't life or death. So the benefits don't outweigh the risks in that scenario.
And then I feel like in ENT, we love questionnaires. Are there questionnaires for like the aging face or for your facelift candidates that's part of your history?
So I don't have a questionnaire that's a part of my history, but we do, from just a business and kind of marketing standpoint, we do contact the consultations ahead of time to get a feel for why they're coming in, what's bothering them. Are they aware of the downtime associated with the facelift? So it's almost kind of like a screening, because sometimes people don't really have realistic expectations, and we just want to kind of set the tone from the start. So it is a questionnaire in a way, but a little different than I think what you guys traditionally do.
Yeah, no, I think that's pretty cool because, like you said, it sets expectations on both sides for you and the patient. And so when they're coming in, it kind of saves everybody a little bit more time and probably makes communication better.
It makes it much more efficient, which, as you remember, for me, I'm like king of efficiency or trying to be efficient. So yeah, they were kind of on the same page from the get-go. It's not like, oh my God, I thought, you were going to do this and you're recommending this. Like we're, walking hand in hand with the patient from the first step they take into the office.
Yeah, that's pretty cool. In terms of thinking about facial analysis and your physical exam, you mentioned you are looking with the patient sitting down, they have a mirror. How do you analyze the face and like what is part of your exam?
Yeah. So for a traditional facelift consultation, I just feel like to be consistent and organized, we really just kind of go top down. So I start with their forehead and their brow position. The most common adjunct procedure I do at the same time as a facelift is an upper eyelid blepharoplasty. So I'm looking to see if the patient has dermatochalasis, both in their upper or lower lids. Usually in the lower lids, there can be skin laxity or perhaps infraorbital fat pad herniation. Then I'm looking to their nasolabial folds, their jowls, obviously the quality and the texture of their skin. And then really I kind of migrate inferiorly to the neck. I'm looking to see if they have, a lot of subcutaneous fat. Is the deep neck fat that I was referring to earlier? Do they have platysmal banding? How lax is their skin? And then another area really is the upper lip. And so as a patient ages, the upper lip distance elongates. So the space from like the columella to the top of the upper lip. And there's a procedure that I also do a lot of called the lip lift. So we design a bullhorn shape, and that's right at the base of the nose. And so the scar heals right into that crease there. And a sign of youth, or a sort of quote unquote sexy feature, is to have a little bit of an upturn to the wet part of the lip and a shorter distance there. So that's also something that I'm taking into consideration when I'm evaluating the patients.
So my exposure, it's been so long, to the cosmetic patients. This was years ago during residency. And I remember photography and pictures, especially for the rhinoplasty patients. Is that part of your evaluation for, a facelift patient? Is photography or any of that important?
Yes. Yeah. We take preoperative photos. We do frontal, oblique views, profile views, and then also what we kind of call the chin down view. So we have the patients kind of look towards their feet. It shows if they have a lot of bunching of skin and subcutaneous fat in their neck. And so, of course, we do preoperative and then usually postoperative photos about 6 to 8 weeks later, once all of the swelling and everything's gone down. And that actually is very helpful to then, patients come in, they're like, what am I going to look like? And so with consent of prior patients, we will show their other patients' photos to the new patient. And that really helps put them at ease when they see how, natural it can be done. And the scarring with time fades nicely. And, sometimes you really have to get up close and personal to even notice the scars.
In terms of the photography, so is it similar to the rhinoplasty positions? You'd mentioned frontal, oblique. Chin down is not, I think, different, right? It's not part of your rhinoplasty.
Correct. Yeah.
So there's a certain different ones that you take.
Yeah, a couple different. With the rhinoplasty, we do like a base view. So that instead of chin down, the chin kind of tilts upwards, so you can see the nose in that perspective as well. But fairly similar.
I just remember the blue background. Does everybody use the blue background?
So I have a black background. I think it shows up a little bit better, but I don't think there's any kind of quote unquote gold standard when it comes to that. You look at other plastic surgeons' websites or their photos online, and everyone seems to have something slightly different.
And two questions. One is, what kind of camera do you use? And then is it just your iPhone camera? Or I just remember my attending having a big Nikon with a lens on it. And then two, how do you learn to take these photos? Where did you learn? You know what I mean? Because I feel like I remember he would be like, okay, take these photos. And I take them and he would have to delete all of them and retake them.
Yeah, you're taking me back to my fellowship too.
Yeah.
So now, honestly, with the quality of the iPhone, we use an iPhone, and it's nice too because it integrates. So we have two electronic medical records. I use a platform called Dr. Chrono and another iCloud-based photo storage. It's called RX Photo, and they integrate. So you can take the photos on RX, and then it automatically associates the photos with the patient in our electronic medical record. So it's great. And the photo qualities with the new iPhones is excellent. I mean, to invest in a really expensive camera, it just seems a little unnecessary. And I like the ease and the safety of it just going straight from the iPhone camera to the iCloud, secure system. So that's what we do. And I think a lot of doctors have transitioned to that as well.
That's really cool. Do you take measurements? Like, are you measuring angles or have a caliper out? Do you do any of that on the photo, or is there anything like that going on?
I don't do that in the photo, but I, of course, have calipers. And so, for example, when I'm doing an upper eyelid blepharoplasty, I'm measuring where the eyelid crease is and how much skin I can safely remove and make sure it's consistent from left to right. And so if I'm doing a lip lift, say I'm doing a 5mm lip lift, I'll use the caliper for that and make sure all my measurements are consistent. I'm doing my measurements more like on the patient precisely than perhaps on a photo or anything like that.
And so what are the measurements that you usually document?
So, for example, on an eyelid blepharoplasty, I'm measuring from the lashes to the crease. And then I'm also measuring precisely how much skin I can safely remove without provoking lag ophthalmos. And a lip lift, measuring kind of 5 points in the very midline from the columella to the cupid's bow to the middle of the cupid's bow, and then from the sides of the columella, and then sort of a more lateral measurement as well. And usually, again, depending on the patient, but say they're all roughly about 5mm. But those are in a facelift. You don't really do measurements or anything like that.
Okay. I didn't know if there was something you measure for how much skin you can take for.
It's more just kind of after a couple hundred, you get a feel for how much you can take out.
Okay. So, we keep throwing around facelifts and non-surgical and surgical. Can you just kind of organize it for me? So tell me first about sort of the non-surgical facelift options, and then plastics is such a language, right? If you don't know the vocabulary and the language, it's hard to know. So when we talk about traditional versus SMAS versus deep, can you just kind of go through first non-surgical and then organize the surgical for me?
Yeah, for sure. So I think within the non-surgical, you can say sort of non-invasive and minimally invasive. So something non-invasive would be like microneedling or radiofrequency microneedling. There's a radiofrequency microneedling is basically where I have this platform where 24 needles come out, they penetrate the skin, and they're delivering radiofrequency energy into the papillary and the reticular dermis. And basically that is promoting new collagen formation, which of course, as you know, is going to help sort of improve the texture of the skin. You get some skin tightening as well. We usually do 3 sessions. You space them out a month apart because that's the time period it takes for the collagen to rebuild. And you'll see some nice improvements, mostly in the quality and the texture of the skin. I tell patients, your pores will improve. Again, the texture and the quality of the skin. You will see a little bit of improvement in the laxity. Botox and fillers, I would say, fall within a non-invasive category as well. Botox are neuromodulators, which we use for frown lines and forehead lines and crow's feet. They have other causes as well, especially reconstructive patients. Need facial reanimation, sometimes there's kinesis issues, and you could, do Botox to help alleviate that. Then fillers or hyaluronic acid. So we already have hyaluronic acid in the skin surface. And basically, you're providing volume to a patient in areas where they're a little depleted. I know there's been tons of marketing as far as like a liquid facelift, if you will. I'm not a huge proponent of that. I just think sometimes that people can look overdone and fake, and you're injecting 5-6 syringes, that adds up financially, and, it's only going to last 6-9 months.
Just to clarify, the liquid facelift, is that part of your HA fillers or is that different?
Yeah, that's HA fillers.
That's it.
Or it could be
It.
something called Sculptra. Yeah. It
Okay.
could be Sculptra, Radius. There's different types of fillers. And so I just, now that I do so many deep plane facelifts, that I'm more proponent of something that I know is going to last, probably 10 plus years. It'll really give them the result they're looking for. And, then they won't have to be injecting their faces with all these fillers and such. But, to each their own. And so some people just, that's the route they want to go. Then I think a step up in our totem pole is minimally invasive procedures. So we have something, it's called radiofrequency-assisted lipolysis. So what I do is I make tiny access or port sites underneath each lobule, and then right underneath the chin and the submental crease. I basically use a 15 blade to make like a tiny nick in the skin. And then it's enough space to allow the probe, but in this case, the device is called FaceTite. TITE is how they market it. Anyway, the probe goes underneath the skin and is delivering, again, energy that is supposed to kind of cause coagulation to the adipocytes in the subcutaneous tissue and the subcutaneous fat, and also promote skin tightening. Now, that can work very well for some patients. Usually for patients in their 20s, 30s, early 40s, what we refer to kind of as these gap patients. So they're in between the injections and they're not perhaps quite ready for a neck lift or face. And so this is a procedure that I do in my office under local anesthesia. We provide perhaps, 4 milligrams of Valium. We have, tramadol if they need be, or extra strength Tylenol. We have Pronox, which is laughing gas. And that really provides for a very comfortable setting. I inject a couple hundred cc's of tumescent, so basically dilute lidocaine, and they tolerate the procedure very well. It takes less than an hour, and they can get a really nice result as far as kind of jawline contouring and improving the tightness in their neck. And then, of course, the step up from there would be something more invasive like a face or neck lift. And as you mentioned, yes, there are definitely different techniques in performing a radiodectomy. And now we really just kind of refer to it as a facelift. That was the more traditional term for it. And my preferred technique is what's referred to as a deep plane lift. And that's what I learned from Sam Hamra, who was the initial author, and back in the early 90s, he wrote about it. And now it's kind of caught on like wildfire. And what that is doing, you're elevating the SMAS in the face. And as we know, the SMAS is continuous with the platysma on the neck. So that, I think, provides patients with a profound difference, and it's something that's long lasting.
Just going back to the minimally invasive technique, you said that that's sort of for the gap ages from 20 to 40. Is there anything preventative about that? We think of like people getting Botox earlier on to try to prevent wrinkles and things like that. Is there any prevention with that?
I do think starting Botox, it lasts usually about 3 to 4 months, but even if you do it once or twice a year, it will likely prevent the lines from deepening as you age. So staying on top of it, I think will be helpful. Next thing you know, if you've never done it in your 60s, then you could have really deep furrows. So it can be prevented in that regard. Of course, good skincare when you go out, wear sunscreen. I think that's huge and really overlooked to avoiding all the sun damages. And, not only just obviously the risk of skin cancer, but also just taking good care of your skin. So those are the main things I think to help to prevent anything as you age.
And then in terms of your tumescence, what's your dilution measurement?
So one thing that I'm not sure if you guys are using a lot of at the hospital, but I am a huge fan of TXA, tranexamic acid. So my usual facelift tumescence is actually kind of easy to remember. It's 50 cc's of normal saline. It's 50 cc's of plain 1% lidocaine, 50 cc's of plain 0.25% Morcaine, 10 cc's of TXA, and then 1 cc of fresh 1 to 1,000 epinephrine. And I think TXA honestly has been a game changer, at least for me, in sort of an aesthetic surgery. When I was a fellow, my fellowship director wasn't using TXA at the time, and some of the patients would have really tremendous bruising and swelling. And he's an excellent surgeon, and he wasn't using TXA at that time. And I started, when I got into practice, I had heard of this other plastic surgeon in New York City using it. And so I started doing it. And I mean, some of these patients honestly can get by without a bruise. It's honestly really incredible. So I definitely include it. I use it in pretty much anything I'm trying to do. I think and you can also prescribe it as a oral tablet too, if you're doing in-office procedures, and you can just have the patients take it postoperatively.
That's interesting. Okay. You mentioned some local anesthetics and you mentioned Pronox and tramadol. Do you have to have like a special sedation license, or do you have a sedation nurse?
So Pronox, it's just like a 30-second onset, and then it goes away in a minute. So it's very short acting. And with tramadol, that's just a tablet. So that's just like prescribing someone narco or whatever. So technically anybody, or not anyone, but a physician, you can do that in your office. I am in the process of building actually from ground up a new office with a surgery center attached to it. And I'm working with a company to help me get it credentialed. It would be Quad A SF credentialing. And in that facility, we are able to do obviously local anesthesia. You can do IV. So I truly do the majority of my facelifts under IV anesthesia, so propofol drip. And I have a board certified anesthesiologist there who's administering medication. So I would never do that just in the office. I have obviously an anesthesiologist there doing it. But I rarely, maybe once a year, do a facelift under general anesthesia. 99.9% of the time it's under propofol.
Okay. And then going back towards the surgical sort of, the facelifts, I think of skin as just like the traditional. And then on the other end, we talked about the deep plane. Where's like the SMAS facelift? I understand the SMAS is part of your deep plane, but can you tell me the differences in that or the nuances?
Yeah. So in the beginning, I think it was the early 1900s is when the first facelift was done, honestly. And that was just skin only. And, if you do that, and some plastic surgeons today will still do that, they may look okay for a couple months, but you're not really addressing the issue, which is the cutaneous ligaments underneath. And that's what's leading to the jowling. You're not releasing any of that, especially in the jowling area and in the neck. You need to address the platysma. Otherwise, they're just still going to look lax down the road. So with the SMAS, the next step was then looking into the SMAS. So there's plication and imbrication. Basically, what you're doing is putting in like a deep suture into the SMAS, and you get control. You have a 2.0 PDS or 2.0 micro, whatever it may be. And if you get a good bite of it, a good purchase of the SMAS, and then tack it back kind of in a posterior fashion, you'll see some lip. Now, you're not actually releasing, though, the most important part, which is the zygomatic cutaneous ligaments, the masseteric cutaneous ligaments, the mandibular cutaneous ligaments, and the cervical retaining ligaments. That is really important. And that's where the significance of the deep plane facelift, because it's addressing release of all those ligaments.
When you started saying that, I'm like, I think I studied that for my boards at some point. And I'm like, oh yeah, there's going to be more mobility now. Gosh. And then I've seen the term mini. What's a mini facelift?
So, people will throw these terms around just for marketing purposes. I think a lot of patients are scared when they hear, oh my God, a full-on facelift. And so sometimes a mini is where maybe they're not making the full extent of their incision. I mean, when I do a facelift, the incision or the scarring kind of extends into the sideburn. It comes around, you go retrotragal in females pretty much all the time, underneath the lobule, into the postauricular crease, and then horizontally across to the occipital hairline, and then I go inferiorly along the occipital hairline. So perhaps it's maybe a patient in their early 40s and they don't need a lot of skin removed, then you'll just kind of make half an incision, if you will.
I see. Okay. And then in terms of like when we talk about in-office facelifts, I would think that pretty much all your non-surgical, so the non-invasive and minimally invasive, RFA, fillers, all that can be done in the office. In terms of the surgical, are all of these on the table for in the office too? What procedures can you do and how do you decide?
So obviously that's where it takes into their medical history. It's really important. So if someone's had a cardiac history, then I'm certainly not, going to be doing anything in the office. But if it's someone maybe in their mid 40s who they're very fit, they don't take any medications, in that case, I would say they could be a candidate for doing this under Valium and local anesthesia. We obviously have monitors and we're monitoring their vitals throughout the procedure. But in that case, it could be very safe. And then again, the patient avoids going through anesthesia. That it's not like there's no risk with obviously going under general anesthesia or even propofol. So this sometimes could be even safer for 'em.
So pretty much theoretically, you can do everything in the office, but it just really, the medical history is obviously going to be important. And are there any patient characteristics where you're like, no, we got to go to the OR? What do you look for where you're like, you're not going to be a candidate other than the cardiac patient?
Yeah. I mean, personality, if someone comes in and they're very anxious, because when they're in the office, they're awake. And so some people will snooze if they're sensitive to the Valium, but other people, the last thing I want is to, have a conversation with them while I'm trying to do surgery. So I want them to be comfortable, but at the same time, I don't want them yapping away at me the whole time. Or if they're really anxious, I don't want them to be, fidgety or moving around, of course. So if I get a sense that the patient's going to be like that, then I just say, hey, let's just do it in the surgery center and you'll be more comfortable. You'll be asleep and all that.
And I would imagine you really have to kind of explain to them and talk to them about what's going to be going on. You could probably tell just based on how they're taking that information in of whether what's going to actually work and not work.
Exactly. 100%.
Okay. So before we get to the day of surgery, what's actually going on, what are your pre-op instructions? Do you have them do things like arnica or, do you have anything that they do to prep them for surgery?
Oh, yes. So we actually have them come in about 3 weeks before their surgery or their procedure, and they meet with my main nurse, Kat, and she sits with each of them for probably an hour and goes over our entire preoperative sheet. And so she'll review their medications, when to take the antibiotics, pain pills. We provide them all with arnica and bromelain pills. If it's a facelift, we have a custom skincare line that we give to them, and she explains that to them as well. And then she'll go through just everything, what to expect if they have drains. So a lot of times I'll actually leave JP drains for 24 or 48 hours in these patients. She'll teach them how to care for them, how to record the output, and how to take care of their sutures, how to clean them, all that stuff. And then we just review with them their appointments. I probably see these people 3 to 4 times in the first 10 days. So we really have them come back to the office often to make sure everything's, healing as well as possible.
And we'll talk about post-op in a second, but you said the TXA oral, is that part of your post-op or do you ever do that pre-op too?
If I'm including it in my tumescence, I usually won't give it as a post-op as well. I think just in the tumescence is enough. Obviously, especially if someone has a history of clots or anything like that, then you probably won't even want to give it in the first place. So I make sure before I do that. But I think in the tumescence, that's plenty. If it's something maybe I'm doing like an upper eyelid blepharoplasty alone in the office, where in that case, I'll just use traditional local at 1% lidocaine with 1 to 100,000 epinephrine. Maybe in that case, that patient could warrant some postoperative TXA. But yeah, for the most part, it's in my tumescence.
Okay. And so now we're there day of, we're going to do the procedure. We talked a little bit about hemostasis and sedation. Is it basically the tumescence and with the TXA in it? That's also going to have your local in it. And then you also do a little Pronox and some Valium and Tramadol if they need it.
Correct. For the in-office procedures, correct.
What instruments do you like to have on your back table?
Oh, we've got it. That's kind of taken some trial and error, but we've got that down now to a T. I think the most important instruments are my lighted facelift retractors. So I have 3 now. I have I guess similar to like a lighted off-richt retractor that I use. It's very narrow, and I use that when I'm doing the platysmoplasties because it can fit through a small cemental crease. For the neck, I have a maybe 5-inch lighted facelift retractor, and then one that's maybe like 8 inches. So I use the 8-inch when I'm trying to elevate the skin flap in the neck. So I get all the way, like I'm connecting my flaps I basically have very wide undermining from the right ear to the left ear and, across the chin, of course. And when I elevate the deep plane, I will switch then to the 5-inch lighted retractor. And with my left hand, I am holding up the skin and the SMAS with the lighted retractor. And then I have a facelift scissor in my right hand that I'm elevating in a vertical fashion to, create the flap. So basically my 2 or 3 facelift scissors and my lighted retractors, I would say, are my most important instruments.
And then in terms of hemostasis, do you have any bipolar tricks? Pledgets and Afrin? What do you do for that?
I do honestly, it's just Bovie and bipolar. It's funny when you transition from, the big hospitals where you have every, gadget under the sun. It's kind of, I've forgotten about half of them, all the Surgicel and the Fibrillar and the whatever else. I mean, you don't understand it. You don't really appreciate this stuff when you're a resident, but, they're really expensive. And I think the best form of hemostasis is just, being a safe surgeon and being in the right plane. If you're in the right plane, a lot of times you really shouldn't have any bleeding. So I think for me, bipolar is just the number one thing I use for coagulation.
In terms of tricks to raising your flaps, anything that you do differently now or any advice you would give to somebody that's coming out?
Yeah. So I'll start my incisions with a 15 blade, and then a 10 blade in the occipital hairline area. And then it's really getting the right instruments. And, in the beginning, I was operating at this one surgery center and I was just using what they had, and it was kind of frustrating. And so then I reached back out to my mentor and a couple other surgeons I respect. And I was like, what instruments are you using? And they told me, and then I bought those, and it was like a night and day difference. And so I have, like I said, 3 different facelift scissors. And, one I use for elevating the skin flap, one I use for kind of contouring the flap, and the other one for vertical spreads. And the 3 of them really help me be efficient and get in that safe plane.
And then any tricks or pearls to make sure you don't injure any of the facial nerve? I think it's probably staying in the right planes.
Yeah, staying in the right plane. And, that's 15 years of training to help you, be safe, right? That's why residency is so long. That's why you do a fellowship. That's why you watch videos in your free time. I mean, honestly, when I was a resident, that's another thing. I mean, there's QMP, where a couple very well-known facial plastic surgeons will post their videos of this is how I do it. And I mean, I've watched Dr. Andrew Giacono from New York City, who's world-renowned now, and Dr. Mike Nyack, who's also a facial plastic surgeon in St. Louis. They each have their own video series, and they're professionally done, kind of like this here at BackTable with all your fancy microphones and all the stuff that I got to get caught up on. But I watched those videos front to back when I was starting out, or in fellowship and residency. And that really helps you learn how to do these surgeries safely. So, unfortunately, you just eventually got to do it yourself, and you learn from experience. And it's just, the same goes for you or Dr. Trulson doing head and neck cancer, who's done a gazillion parotidectomies. I'm sure he's a lot better now than when he started out day one. So there's really no substitute for experience.
Yeah. In terms of securing the flaps, what kind of sutures do you use? What do you find are your pearls there?
Yeah, I basically incise the SMAS from the lateral canthus, if you can imagine an imaginary line from the lateral canthus to the angle of the mandible. And then I actually extend it. So I'm technically doing an extended deep plane because I'm releasing the cervical retaining ligaments, which are the ligaments between the SEM and the platysma. So I have a long flap that's going all the way, again, basically from the lateral canthus past the angle of the mandible and then into the neck. I'm elevating the platysma about 5 or 6 centimeters down into the neck. And then I create like a little back cut into the SMAS along the mandible. And I'm using 2O PDS. I use about 4 of them in the face. And I'm getting a nice purchase of the SMAS and I'm tacking it back to the fix. So where I cut into the SMAS, we refer to kind of as the mobile SMAS. And the fixed SMAS is right in front of the tragus. And that's where I'm putting in my deep sutures. And so I know that's going to be a good sturdy bite. The sutures aren't going to let go or break or anything like that. And that's when you can really see a tremendous lift in the jowls and the nasolabials. Then I'm taking the platysma, I'm slinging that back behind into the mastoid fascia behind the ear. And that helps create a really sharp, defined jawline. In the neck, when I'm underneath the chin in the platysma, I use 2O Vicryl. I first actually get a deep bite. So I start at the hyoid, at the level of the hyoid, and I work superiorly. I get a bite of the hyoid fascia, and then I do inverting bites from the left and the right edges of the platysma, and then I cinch it down. And I do at least 4 or 5 there all the way up to my incision line. And that is what really helps create that sharp cervicomental angle.
And how do you know you've tacked it up enough? Is that just, again, through experience and kind of doing enough of these?
Yeah, I think that's just where the kind of the art of this comes into play. It's your eye, your eye for aesthetics. And so, does it look good to you? I mean, that's where, I don't really foresee myself ever doing any measurements in this area. It's really mostly like, okay, if this was your mom or your sister or your aunt, like, would you be okay with this, with how she looks? So that's just like caring and honestly having a little bit of a creative mind to making sure it looks good.
And then how do you normally like to close the skin?
So closing the skin, I mean, that's actually I always loved suturing. When I was a resident, I mean, some of my favorite parts sometimes were when we were at the end and you get to stitch up the skin. I've always liked that.
They step away, you're kind of in
yeah, exactly.
the music's kind of setting in, and you're like, okay,
exactly.
I'm about to go eat soon too. Yay.
Yeah. You get to change the music finally to something you like. And then, So I will use, a lot of it is running locking 5-O-proline. I'll do always 2-layer sutures to obviously take off tension on the skin edges. So, 5-O Vicryl or whatever it may be for deep dermals. And then I really like 5-O running locking. I will, in front of the tragus, that's kind of a tough area sometimes to remove stitches, or I should say retrotragal. So in that area, I've now actually switched to 5-O chromic. Around the lobule, again, 5-O nylon. In the postauricular crease, I use 4-O plane at the moment. And then in the occipital hairline, it's 4-O running locking. And then the chin, again, 5-O Vicryl, and then a 5-O running locking. So I'm sure like most surgeons, you go through 100 different types of techniques and sutures. And then I guess eventually you settle on something you like. So that's where I am currently. And I would say in the last 6-9 months, I've been really pleased with the results, at least aesthetically, from the scarring with that.
And any thoughts on skin glue?
I don't use it. I've visited a lot of facial plastic surgeons over the years. I haven't seen one that I can remember. I mean, it's different if it's like a 2-year-old who comes, as a friend's kid who's got a little nick, and the last thing you want to do is create more trauma. I think, and they'll heal obviously tremendously well. So that could be fine, but in your adult patient population, I don't think that's satisfactory.
In terms of your post-op instructions, what is part of their post-op routine? Anything special? Anything that you have them do?
So they all, as I mentioned earlier, they all get arnica and bromelain for bruising and swelling. We give them a scar cream to start applying once the stitches come out. We have them undergo hyperbaric oxygen. We have them undergo lymphatic massages. That's actually a big component as well, which I think really helps, their circulation and get some of the drainage out. And we have them keep, the ones who listen, and really keep the suture line clean. That's really important and just easy on us, honestly, too, when they come back to have them removed. And then just avoiding any like heavy straining or exertion. Some of these patients just like they're affluent or successful businessmen and women, and they want to get back to their lives. And so some of them are workout junkies. And so it's like, hey, just take it, like let your body heal, take it easy, and promise, you'll get back to that before you know it. But I don't want you to, stress yourself too soon.
Yeah. In terms of the HBO or the lymphatic massage, when do you start that post-op?
So usually post-op day 1, they go for hyperbaric oxygen. You really want to find a facility that can at least, get up to 2 APMs. I think, if you're at 1.4, 1.5, it's almost like, not really doing anything. So ideally you can get up to 2. And then the lymphatic massage is usually like post-op day 3 or 4. They'll love that. We have an esthetician here in my office. She's excellent, Ari. And she's actually also coexists as my social media manager. And she's now a trained esthetician, and she's great. And they'll usually get a package with her after the first one that we include for them. And they'll usually end up doing like 3 more or so.
Okay. And then in terms of complications, how do you counsel patients, and what have you seen in practice?
Of course, we have, it's in our consent forms, and the traditional with most of our skin soft tissue surgeries. So hematoma, it's fortunately very rare, maybe 1 in 100. We talk about sensory issues. So it's more likely, if anything, nerve related, it's going to be perhaps you cauterize or bovie next or bipolar, close to the greater rick. And so they're a little bit numb behind their ear. Facial paralysis is actually very rare. And in fact, the rate of complication from that is the same if you're doing a deep plane versus a SMAS surgery. So any surgeon who's going to tell you that it's safer to do that, that's not actually technically true based on research. Now, scarring, bruising, swelling, of course, is expected. I think those are the main complications.
So as we start to wrap it up, any final pearls? Like, I've learned so much, Demetri, and I'm like so in awe. I think you have an amazing practice, and I would love to have you back on to talk more about practice building and also about this custom skincare line. Very cool.
Yeah.
But before we get in, any final pearls?
Well, for any of the residents, listening out there, anyone still in training for that matter, I mean, really take advantage of your time in residency, because you're never going to get that back when you're going to have 20, 30, 40, faculty members around you who, all do things a little different. And that's honestly one of I know it's crazy to say, but I love my residency. You guys were awesome at UT Southwestern. I'll be forever grateful for the training I received there. And honestly, just the camaraderie that you develop amongst your co-residents and the faculty. I mean, you know me, I feel like I was laughing half the time, and you're busting your ass and working hard, but I loved it. So I would say, take advantage of, try to learn. You pick up, one or two pearls from each of your attendings and try to, what you think works best for you, and incorporate that into your practice moving forward. And if you know what you want to do with your career, early on, then, I obviously want to get a broad training, but at the same time, I don't think it's a bad thing to kind of, hone in on, the laryngologist, if that's what you want to do, or facial plastic surgery. And for me, like I said, the best thing I ever did was to, leech on to the guys that we had at Southwestern, but also go out into the community and see different, perspectives. So anyway, I just think take advantage of that time. And I think by and large, everyone is welcoming. There, no one's going to turn you down and be like, no, I don't want you to be there. So, you got to shoot your shot. It can't hurt to at least ask and be like, hey, I would like to come and serve. And I'm sure people will definitely embrace you with open arms.
That's awesome. Well, thank you so much, Demetri, for taking the time. If any of our listeners want to reach out to you, you have a beautiful website. Is it drdemetrimd.com? Is that correct?
Yeah, that's right. Or they could shoot me a message on, I think everyone's so plugged into social media these days. So my Instagram, you can send me a message. It's Demetri, Demetri. And I'd be happy to connect and share more thoughts, or have you in to hang out with us for a day or a week or whatever it may be.
That's awesome. Well, thank you again. I think it's a wrap.
All right. Thanks so much for having me. It was a privilege to be here.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Ivan Orgodzinsky.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.